Hi, I'm going to talk about the ABCs. I think we talk about the ABCs so much in nursing school that everybody gets to the point they're like, yeah, I got that. But the ABCs are actually very complex and very important. They're basically the concepts of oxygenation and perfusion. So we're trying to get the oxygen from the external environment to every cell in the body. And when problems occur along the pathway that oxygen travels, that is an ABC problem. And the more towards the start or beginning of that pathway that the problem is, the higher the priority. So I'm going to make one point of clarification before we get into airway that gets a lot of people confused. As the oxygen is traveling from the external environment to every cell in the body, it has to pass through the pulmonary and cardiovascular systems. And to pass through those, it has a delivery mechanism. So in the pulmonary system, the oxygen travels in air. So we would measure the air volume in milliliters or liters, but we look at how much oxygen is in that air by using a percentage like FiO2 or a partial pressure, PO2. So for example, we could have a patient that's breathing 500 milliliters of air per breath, and that air may have about 20% oxygen or 20% FiO2. That's about room air. Or we could have someone breathing 400 milliliters of air, but we're giving them supplemental oxygen, so they have 60% FiO2. So they're both very important to assess, but they're separate, and they need to be assessed separately. In the cardiovascular system, the oxygen travels in blood, and blood volume is measured in milliliters or liters, and again, the oxygen within that blood is measured in percentage, for example, like an SaO2 or a partial pressure, like a PaO2. Okay, so what's the first thing that has to happen to get the oxygen from the external environment into the alveoli? First, the airway has to be open. So by airway, we're talking about the oral and nasal airways, the trachea, the bronchioles. That pathway has to be open. If it's obstructed or partially obstructed, the nursing diagnosis for that is ineffective airway clearance. And when ineffective airway clearance is present, it's always going to be your number one priority, because it really doesn't matter what's happening past that point if oxygen can't get through the airway. So what are some problems that could cause your airway to become obstructed or partially obstructed? Of course, you could choke on something. Your patient could develop a tumor that would block off part of the airway, that could grow and block the airway. You could get a mucus plug that could block off part of the airway, or you could have secretions in the airway that could partially obstruct. So normally if we have secretions, we just cough them up, but if our patients are really weak, they may not be able to cough them up, and we may have to deep suction them to help them clear those secretions. Another example is somebody with a decreased level of consciousness. They can't protect their own airway, so we have to do it for them with an artificial airway. And then the airway itself can become inflamed. One disease process where that occurs is asthma. So they get the tissue of the airway gets inflamed and narrows, where not as much air can get through the airway. So anytime your patient has an obstructed or partially obstructed airway, that is going to be the first thing you're going to do is try to get that airway open. Now, what's the next thing that needs to happen to get the air from the external environment into the alveoli? The patient needs to take a breath. So now we're talking about the physical act or work of breathing. When we talk about that, we'll refer to that as ventilation. Ventilation is basically your nervous system tells your respiratory muscles, including your diaphragm, to breathe, and the muscles have to have the ability to do that. So when you have a problem with ventilation, the nursing diagnosis for that is ineffective breathing pattern. When we're assessing ventilation, one good thing to look at is minute ventilation. So that's how much air your patient is moving in a minute. And again, we're looking at milliliters because we're talking about the air. So tidal volume is how much air your patient moves in one breath. So you can change your tidal volume right now by taking a shallow breath or taking a deep breath. And then we would multiply that by how many times they're breathing in a minute. And that would give us how many milliliters they're moving per minute. So one example, if they're moving 500 milliliters in one breath and they breathe 12 times a minute, that gives them 6,000 milliliters a minute, which is a good minute ventilation for an adult. If we have problems with either tidal volume or respiratory rate, that's going to reduce the amount of air they're moving. So 300 milliliters with 10 breaths would only give us an inadequate amount of 3,000 milliliters per minute. And normally, when our tidal volume goes down, respiratory rate will go up to compensate when it's able. So if you had a low tidal volume of 200, you might see your patient's respiratory rate come up to 30 to equal that same 6,000 milliliters per minute of tidal volume. So when we're looking at problems with ventilation, you're either going to have a problem with the tidal volume or the respiratory rate. So what can cause that? Since your nervous system and your muscles are involved with the work of breathing, if you have, say, a medication that your patient's on that can depress the central nervous system, that can cause them to breathe slower or more shallow. If they have a neuromuscular disorder like ALS or MS that's deteriorating the nerves, and so the muscles for breathing aren't working properly. If they have a spinal cord injury that's above T4, that can affect the muscles that are used for breathing. You could also actually have a physical obstruction to breathing, so your patient's trying to take a breath, but like, for example, a large abdomen, they're obese, or they have ascites, or maybe they have fluid in the lining around their lungs. That's called a pleural effusion, and that can stop them from expanding their lungs and getting a good deep breath in. One thing that's pretty common in the hospital is patients are weak and they're immobile. So they're laying down and they're not taking good deep breaths. Confusion can add to that even more. And then pain is another big thing. So if they have pain in the chest or abdomen and it actually hurts them to take a deep breath, they may have a lower tidal volume because they're not taking good deep breath. We have some great nursing interventions for ventilation. Of course, if they're in pain, we want to control that pain so they can breathe deep. But deep breathing, incentive spirometer, getting your patient up and moving up in the chair, ambulating, are all things that are really important for ventilation. Also, when we're assessing ventilation, we could look at respiratory rate, depth, effort. We can look at pulmonary function tests. It'll tell us actually how many milliliters of air they are moving. But one thing I want to mention in particular is CO2. Because you may not think about CO2 when you think about ventilation, but how does our body get rid of carbon dioxide? We exhale it or breathe it out. So if we're not having good ventilation, we don't expel an adequate amount of carbon dioxide, then our CO2 level is going to go up. So that can be an indicator of poor ventilation. Whereas if we're breathing off too much, say we're hyperventilating, we're breathing off too much air, our carbon dioxide level will be low. So we can check CO2 in the blood with a partial pressure, like PaCO2. That would be if it was in an artery, and V if it's in a vein. But we can also do that non-invasively with an end-tidal CO2 monitor. So this is an example of one on a nasal cannula that would be hooked to a monitor that could tell you the CO2 level. So an example of when you might use this is you have a patient at risk for a ventilation problem. Remember we talked about a CNS depressant. So maybe your patient just had surgery or they're on a PCA pump, and you're worried about CNS depression with those medications. You could have them on end-tidal CO2 monitoring. If you start to see the CO2 increase, then that's an indicator they're not moving enough air, so you may need to help them with their ventilation by either decreasing or reversing the medication or assisting them with ventilation. Okay, so now we have an open airway. We have a patient that took a good deep breath and they have air in their alveoli. So now how is that air going to get, or the oxygen in that air rather, get from the pulmonary system in the alveoli into the capillaries or the cardiovascular system? So the blood has been brought from the right side of the heart through the pulmonary artery into these pulmonary capillaries, and the pulmonary capillaries are surrounding the alveoli. The alveoli have a semi-permeable membrane, and the capillaries are a semi-permeable membrane. And they are both very permeable to oxygen and carbon dioxide. So what causes the pressure to actually make the oxygen and carbon dioxide move? That pressure is called diffusion. It does not require any energy. It's moving from an area of higher concentration to an area of lower concentration. So it's actually the difference in the concentrations that drives the movement. So you see in this one on the left side has a higher concentration of particles. We'll say these are oxygen. And on the right of that membrane, there is a lower concentration. So that is going to drive the oxygen particles to go across that semipermeable membrane to equal out the concentration on the both sides. So in the end result, we have equal concentration of oxygen on both sides of the membrane. So we have our alveoli that are covered with blood vessels, and the picture on the right is representative of what's going on inside of those. So we've just breathed in air, hopefully, that has a high percentage of oxygen. So we have a lot of oxygen in the alveolus. So that's increasing that amount. And then the blood coming back from the body has just delivered oxygen to the cells. So there's not as much oxygen left in the blood. So we have a lower concentration of oxygen in the blood than we do in the alveolus. And this causes the air to diffuse through that alveolar membrane and the capillary membrane into the bloodstream. So hopefully we get a good amount of oxygen into the bloodstream that's now going to go to the left side of the heart to be delivered to the body. So if we have a problem in this process, the nursing diagnosis for this is impaired gas exchange. So there are a number of things that can cause problems. One we kind of talked about was the difference in partial pressure between the oxygen in the alveoli and the oxygen in the bloodstream. Another one is surface area. So the alveolar membrane has to make contact with the capillary. And if either one of those are out of place and they're not making contact, then you won't have gas exchange occurring. One example of that is atelectasis. So the alveoli is kind of like a balloon where you breathe in and it expands and then you exhale. So if for some reason the patient is not getting enough air into their alveoli, then they're not going to expand. So they're going to stay, I guess, shrunken up if you think of it that way, and they're not making contact with the capillary. That would cause an impaired gas exchange. Another one is if anything gets in that membrane to thicken it. One example would be pulmonary edema. So we have fluid coming out of the vascular system and into the alveoli. Then they can get fluid down in here, and that fluid impedes the gas exchange. Another example would be pneumonia. So there's an infection which causes an inflammatory response, and the inflammatory response results in an inflamed and thickened alveolar membrane, and then fluid can develop in the alveolus, and you could also get sputum. All of those are going to impede gas exchange. When we're assessing oxygenation or gas exchange, we're going to look more at the oxygen content. Remember when we were assessing ventilation, we were looking at the milliliters or liters of air. Now we're going to look at how much oxygen is in that air. So we'll be looking at things like FiO2. That's the amount of oxygen that's in the air that the patient is breathing in. Partial pressures of oxygen can be measured. You can, if in the artery, that would be PaO2, or in the vein, PVO2. So that's the partial pressure of oxygen that's dissolved in the blood. So that's oxygen actually in the blood. You can also measure an oxygen saturation, SaO2, SVO2 if it's artery or vein. SpO2 would be when we measure it with a pulse oximeter, but all these are the percentage of hemoglobin that are saturated with oxygen. So this is the oxygen riding on the hemoglobin, which is the vast majority of oxygen that's delivered to the tissues. So as we're talking about delivery in the blood or perfusion, I do want to take a step back and mention pulmonary perfusion, which we've kind of been talking about a little bit, but there has to be perfusion of blood from the right side of the heart that's pumped through that pulmonary artery into the pulmonary capillaries and then through the pulmonary vein and back to the left side of the heart. All that blood has to be there for gas exchange to occur. So one example of a problem that can occur here is a pulmonary embolus. So if your patient got a blood clot and blocked off part of the pulmonary artery, then the blood would not be getting through to the alveoli in that area, so gas exchange would not occur. Can also cause hemodynamic problems as the blood backs up towards the right side of the heart. Okay, so now we're going to look at circulation. So we're talking about cardiac output, which is pumping the blood from the left heart to the entire body. When we're looking at the formula for cardiac output, it might kind of remind you of the formula for minute ventilation. We're looking at the milliliters with each beat. So the milliliters that the heart ejects with each beat is called stroke volume. And then you would multiply that by how many times the heart beats per minute. And that would give you how many milliliters or how many liters the heart ejects, the volume of blood it ejects in a minute. So if you have problems with either the heart rate or stroke volume, then the cardiac output is going to go down. Heart rate's the easiest one to measure, and more obvious, and the stroke volume's a little more complicated. So stroke volume is based on the interactions between contractility, afterload, and preload. So you have to look at all of these to see what's going on with your patient and why their cardiac output is low. One example for contractility would be somebody who just has a weak left heart. They don't have a good contraction, and that itself can decrease their cardiac output. Or maybe you have someone who's very vasodilated. Maybe they're in a shock state, or they took too much blood pressure medication, so that decreases the afterload or the resistance the heart has to overcome to eject the blood, and that can decrease cardiac output. Then preload is the volume of blood that goes into the left ventricle during diastole before it ejects the blood. So the more volume that goes in, generally, the more that's going to be ejected. So preload can be decreased because blood being maldistributed or in the wrong place, but it can also be decreased just because you've lost it. That's called absolute hypovolemia. That's when your patient's bleeding or they're dehydrated, they don't have the volume in their vascular space. So if you have problems with heart rate, contractility, afterload, preload, anything that's decreasing that cardiac output, the nursing diagnosis is decreased cardiac output. But if the problem is specifically with preload and it's absolute preload loss, you could also use deficient fluid volume to be more specific about what's going on with your patient. Okay, so cardiac output, if we have it adequately, hopefully, is going to be the left ventricle is going to inject the blood into the aorta, and then that's going to branch off into arteries and arterioles and deliver blood to every cell in the body. So if we have good cardiac output, but we have a problem to one area of the body, the nursing diagnosis for that is ineffective tissue perfusion. These are a couple examples of that. So you could have, when the blood is ejected from the left heart into the aorta, the first place it comes back to is through the coronary arteries to give oxygen to the heart muscle. So if one of the coronary arteries gets blocked, then that would cause the blood and oxygen not to be able to get through to the muscle, and that muscle will become ischemic. So that could be ischemic heart disease or myocardial infarction. So when that occurs, we would just name that tissue. So it would be ineffective cardiac tissue perfusion. Same thing with the brain. So when the blood's headed up towards the brain, if there becomes a problem like a clot that stops blood flow to the brain, then we would call that ineffective cerebral tissue perfusion. And then if it was anywhere else in the body, you would just name that tissue. So if there's an arterial clot in an extremity, that would be ineffective peripheral tissue perfusion, renal, gastrointestinal. You get the idea with that. So once that oxygen reaches every cell in the body, then cellular gas exchange occurs. You may also hear this called internal respiration. So what we talked about earlier was gas exchange in the lungs, and that would be called external respiration or external gas exchange, because you're getting the oxygen from the external environment and you're expelling the CO2 to that environment. But the same thing's occurring on the cellular level, except for this is now internal, and it's a little bit different because now we have more oxygen in the blood than we do in the cells. So diffusion's still going to occur, but this time it occurs from the high concentration in the bloodstream towards the low concentration in the cell. So you have oxygen moving from the bloodstream into the cell, and then the cell needs to get rid of their byproduct of CO2. So we have a high concentration of CO2 in the cells and less in the blood. So the CO2 will diffuse into the blood. So then we have blood going back that now has less oxygen in it because it just delivered the oxygen to the cells, and it has more carbon dioxide because it took that waste product from the cells, goes back up to the right side of the heart, gets pumped to the lungs where it picks up oxygen and gets rid of the CO2. You exhale the CO2 out, and then the oxygenated blood goes back to the left side of the heart to be pumped to the whole body. So that is the process of the ABCs.